most importantly we will discuss about the upper limb. So while seeing an x-rays, there are so many things we have to notice. In that, first we have to check whether the x-ray has taken in correct form or not. So before finding any radiological things, we have to confirm whether the x-ray is taken in a correct form or not, like whether the x-ray is overexposed or low exposed. Okay, how can we predict these things, like overexposed and underexposed? So th- this is very simple topic. So in the case of overexposed, like the radiations is overexposed to the patient's body, then the bones, we can't see the bones clearly. Those bones look like the black shadows. You can't see the white shadows. Like, let's take this as an example. So in this X-ray, you can see the bones like ribs, clavicle, humerus. These bones and all you can clearly see in the white shadows. But if this X-ray is overexposed, okay, if this X-ray is overexposed, then you can't clearly see these white shadows. Some of the area will look like black shadows, in or you can notice something. You even in some X-rays you may get confused whether it's an whether it's an overexposed or some kind of tumors that look like a shadow. So if you have confusion, then you should check for some specific things, like in x-rays in the AP view you should check for the middle border of the scapula. This is the middle border. In most of the x-rays, the middle border, you can't clearly see the middle border in a normal x-rays. If you can clearly see the middle border of the scapula, then the x-ray is overexposed. It's little bit overexposed. Okay, so if the x-ray gets overexposed means, then you can't. Someone is drawing, it seems. Okay, if the x-ray is overexposed, then you can't clearly identify some clinical features like the fractures or some tumors, even some anatomical structures. So, if the most common thing that we can't diagnose in an overexposed X-rays are anatomical structures, whether the bone is malformations or any deformities, like the anatomical structures, we can't clearly diagnose in overexposed X-ray. Okay, if the X-ray is underexposed, like low exposed, if the x-ray is low exposed, then you can't clearly see the bones. You can clearly see the clavicle bone here, no? So if the x-ray is, is underexposed, then you can't clearly differentiate between these muscles, between these soft tissues and the bone. Both the soft tissues and the bone uh, will look like the same white shadows, as it's an underexposure. Okay, in that case you can't diagnose anything. If the x-ray is underexposed, then you should definitely retake the x-ray. There is no excuse for those x-rays and all. But if it's an overexposed, in some x-rays, most of the x-rays, the x-rays will be taken as overexposed. In some of the overexposed x-rays, you can diagnose using that, but you can't clearly diagnose using those x-rays. You should clinically correlate with the patients, or you should go for another investigations in the overexposed x-rays. In the low exposed x-rays, the 100% you can't clearly diagnose using that. So if the x-rays is taken in low exposed, then you should avoid those x-rays. If you take a as Y exposed, like overexposed, then you may diagnose using that, but you can't clearly tell. You can't tell 100% in overexposed x-rays. Okay, is that clear? These are the first thing you have to notice in those x-rays, whether the x-ray is taken in the correct form. Then you should take, or you should check whether the position of the patient, whether the x-ray is taken in the correct position. Like if example, uh, if the patient's x-ray, like the shoulder x-ray, if the patient's shoulder x-ray is taken uh, in the rotation of arm, if the patient moved the arm internally, then the head of the humerus will look like posterior dislocations. So in that case, you can't clearly diagnose the dislocations or displacements. Okay. So in that meantime, you should check for the first thing, exposure. Okay. The second is alignment or posture. So whether the X-ray is taken in an anatomical posture. Okay. So these two things you have to confirm, or you have to check before going for diagnosis or any findings. To check any findings, you have to confirm whether it's the X-ray is applicable to diagnose or not. Okay. So these two things you have to check first. Then only you have to go for the specific considerations, like whether to check the joint space or degenerative conditions like PA shoulder, adhesive capsulitis, those things and all you have to check next. Like those findings, fractures and all, you have to check next. Okay. So while checking the X-rays, the first basic things you have to notice is those two things. Then you have to check for the third one. You have to check for joint, joint space, joint space, and joint articular surface. Okay. So these two things you have to check in all the X-rays. It's common for all X-rays. Whether you can take knee X-ray, foot and ankle X-rays, even it's lumbar, cervical X-rays, whatever the X-rays, you have to inspect the joints. Okay. In the shoulder complex, you have to inspect two joints. Okay. Those two joints are acromioclavicular joint and glenohumeral joints. The first one is AC joint, and the second one is glenohumeral joints. So these two joints you have to check. In these two joints, you have to check for the joint space and the articular surface. In a normal X-ray, the articular surface will place uh, parallel to each other. Both the articular surface of the bone, like the acromion and clavicle bones. So these two articular surfaces will placed parallel to each other. If it's unparalleled, okay, if it's unparalleled means then it's a dislocation. Even in some cases, the AC joints will be unparalleled. Like if the patient has any congenital defect or uh, excessive degenerations. If the patient has excessive degeneration means the clavicle part, the clavicle bone will look like small compared with the acromial part. Okay, the clavicle bone will look like small when compared with the acromial part. So in that meantime, uh, it may look like unparalleled. So how can we differentiate those things? So you have to check. So to check the vertical, you have to check for top, also the bottom. Both top and bottom should be unparalleled. The top is unparalleled, but the bottom is parallel. Then it's a normal. If the both top and bottom unparalleled means, then only you have to check this locations. Okay, these for articular surfaces. Then, as for joint surfaces, if the joint surface is reduced, okay, if the space is reduced, then it's maybe either arthritis or soft tissue injury. Okay, soft tissue injury within those joints, like the soft tissue within the AC joints are acromioclavicular ligaments. So, if the joint space is reduced, then it's maybe either arthritis or soft tissue injury. Okay, if the joint space is increased, like you can see big joint space, the joint space is increased, then there may be dislocation either dislocation or soft tissue injury, like the acromioclavicular tear. Okay, if the joint space is decreased, acromioclavicular ligament sprain. If the joint space is increased, then it may be either dislocation or soft tissue injuries like tear. Okay, so in these things, how can we differentiate between the soft tissue injuries and dislocations, and the soft tissue injuries and arthritis? Okay, if for example, uh, you can see the AC joint spaces reduced somewhat. So, how can we differentiate this AC joint is arthritic or soft tissue damages? So, to differentiate these two things, first you have to check for degenerative conditions to confirm the arthritis. So, if the patient has arthritis, there will be three findings noted. The first one is degenerative changes, the second one is osteophytes, and the third one is joint space reduction. Okay, so these three things you have to check to confirm the arthritis. If these three things is not present, then it's not an arthritis, then you can confirm it as a soft tissue injury. The same goes for dislocation. Okay, you have to check for articular surface. If the articular surface is normal, then it's not in dislocation, it's a soft tissue injury. Is that clear? Okay, so to differentiate between the arthritis and soft tissues, you have to check for those three things, that is degenerative changes, osteophytes, and joint space reductions. So what are the degenerative changes that we have to notice, and how it will look like in the X-rays? I will I So in this X-ray, you can see the AC joint, like the space is reduced. Okay, joint space is reduced, and so it may be either arthritis or soft tissue damage. So to confirm the arthritis, we have to check for those three things. The first one is degenerative change. So the degenerative change, it's nothing but the structure of the bone will get malformed. Okay, so the structural alignment of the bone will get changed. Like if the bone look like this, but in and degenerative changes, the bone will be look like this. Okay, so the structure of the bones will get changed. It may be a small change, you can see visibly the changes. So in some of the x-rays you can't clearly differentiate those changes and all. So it may be possible that you may misdiagnose these things, those degenerative changes. So to double check that, we have to check for osteophytes. Osteophytes is nothing but the extra bone formation. Okay, it will look like a spur. So in the AC joints, there is no spur-like formations. Okay, but you can see some degenerations, but there is no spur-like. So it's not AC joint arthritis. So you can see AC joint sprain. Then we have to look for GS joint. Okay, in the GS joints, you can clearly see the joint space is reduced. And in the GS joints, you can't check for joint space because the joint space between the glenoid labrum and the head of the humerus is a little bit small, and you can clearly see those uh, spaces in CT and MRIs. In an X-ray, like the 2D views, in an 2D views, you can clearly see the joint space, like only the GS joint space. Some joint space you can't see. In that GS joint space, you can clearly see in a 2D, two-dimensional views, like the X-rays. If it's a three-dimensional view like CT or MRI, you can clearly see the joint space. So in an X-ray, we have to omit the joint space part in GS joint. Okay. So we have to check for degenerative changes. And you can clearly see here in the graded tubercle, graded tubercle, you can clearly see the structure of the bone is get little bit changed. So there is small, okay, there is small degenerative changes. Degenerative changes noted first. Then you can see the osteophytes, the little bit bone formations here, here too. Okay, some little bit bone formations you can clearly see. So you can see osteophytes. So in the three things, osteophytes positive, degenerative changes positive. And as for joint space, you can't check joint space in the GS joints. So for arthritis, those findings is confirmed. So it's an arthritic conditions. So the arthritis we have to look for in GS joint is PS shoulder, that is periarthritis shoulder. Okay. So this is how you have to diagnose the arthritic conditions. Okay. Then here you can see reduced GS joint space, reduced subacromial space, osteophytes over greater tubercle, and it's an periarthritis shoulder. Okay, these things you have to notice. Then, so I told 3 points. The first one and second one is to check whether the X-ray is taken in correct form or not. Then the third point is to check the joints, to inspect the joint spaces and the vertical surfaces. In that, you have to check for arthritis and soft tissue damage and dislocation and soft tissue damage. And as for dislocations, there are different types of dislocations in different joints. Like, let's take an example. Let's take an example. Okay, if dislocations is noted in spine, okay, If the displacement or dislocation is noted in the spine, it's considered as a listhesis. Okay. If the displacement is noted in a knee joint, the most common dislocations in the knee joints are patellar dislocations. That is lateral dislocation of patella. And in the hip, it's a congenital dysplasia of hip. Okay. And those listes is also differentiated into two types, spondylolisthesis and retrolisthesis. There are what what I am telling means there are different types of dislocations in the different joints. Okay, so you have to look for those specific dislocations. As for now, in the shoulder joints, there are in the shoulder complex there are two joints. The first one is AC joint and the second one is J joint. In the AC joints, there are six types of dislocations according to the Rockwood classifications. Note this point. According to Rockwood classification, ROCKWOOD. Okay, Rockwood classification. There are six types of dislocation in the AC joints, and each and every types will different. And in each and every types, there will be a complete pair of ligaments. Okay, so you have to see those types in the AC. And as for GS joint, there are three types of dislocations. That is most common thing: anterior, posterior, and inferior. Okay, so these are the types of dislocations you have to check in the shoulder complex. Likewise, you have to check for elbow dislocations, carpal bone dislocations, those things and all. Like in the spine, as I told before, you have to check for listhesis. Okay, and in the listhesis, you have to check whether it's an spondylolisthesis or retrolisthesis. Okay, then uh, even though you know the dislocation types, but most of the dislocations you can't clearly diagnose. Why means if we take an example like a 22-year-old male, okay, a 22-year-old male, he is an kabaddi player, okay, and he got displaced his shoulder during the match, and within 2 to 3 minutes, he relocated his shoulder by himself. Okay, then he took an X-ray. Note this point: the shoulder is get dislocated, and he relocated it himself, and then he took an X-ray. Okay, in that X-ray, the vertical surfaces will be parallel to each other. Okay, so how can we tell the dislocations in the X-rays? Can you catch my point? If the X-ray is taken in the dislocated moment, then you can check. But if the patient is relocated, the joints or the reductions done by some other medical, then how can we check for dislocation in those X-rays? So there is one thing that will happen in the dislocations. So if whenever the joints is displaced, there will be a complete or partial tear of ligaments. Along with there will be some fragments of avulsion fractures. Like in the shoulder joints, you can clearly note L7, bunk height lesion, those things. And in an AP, in an X-ray, you can clearly see the bunk lesion here. But the ill-sac lesions you can't clearly see because it's superior and the coracoid process and head of the humerus. Okay, will lie in front of those things, and you can't clearly see the full area of glenoid. So you can't tell the exact lesions in the X-ray. In some of the X-rays, you can notice. So in that time, you have to go for three-dimensional view, that is CT, or you can go for MRI to confirm the soft tissues damage. Okay. So what I am telling means you also have to check the fractured fragments, the avulsion fractures, to check whether the patient had dislocations or not. Even though the articular surfaces is parallel to each other, if there is a bunker lesions or ileocecal lesion, then there may be possibility of dislocations in past. So these are the things you have to check. Then apart from this, you have to check the fourth point, that is osteopenic. You have to check for osteopenic changes and avian, avascular necrosis. Okay, these two things you have to check in the fourth point. So before telling the findings, I will tell about what is osteopenic changes and the difference between the osteopenic and osteoporosis. Okay, so the osteopenic changes is nothing but it's an decreased bone density or decreased calcium levels in some part of bones or overall musculoskeletal region. Okay, it may be due to either post-traumatic conditions after native treatment like plaster of Paris, after POP for fractures. Some patients may have or may leads to have decreased bone density in some areas. Okay, so the osteopenic changes isn't finding; it's not a condition. Note this point: the osteopenic changes is an finding, not a condition. And osteoporosis is a condition. Can you catch my point? The osteopenic changes is an findings, and the osteoporosis is an condition. So to confirm the osteoporosis, you have to check for osteopenic changes. So the osteopenic change is but decreased bone density. It may because of either calcium deposition, I mean decreased calcium, or some other post-operative complications like RSD, some other things. Okay, so you can't clearly decide whether the osteopenic changes has occurred because of osteoporosis. So to confirm the osteoporosis, you have to check the blood infections. Okay, if the patient has osteopenic changes and the blood work also shows the decreased calcium levels, then it's an osteogenic imperfect or osteoporosis. Those things and all you can diagnose. So osteoporosis is a condition and osteopenic is a findings. And I will show you some examples for osteoporosis. Okay. And there is a thing called avian. Avian means avascular. Like avascular necrosis is nothing but the cell death, like the osteoblast and osteoclast presence in the bone will get necrotic, like the cells will get dead, okay, because of decreased blood flow or some vascular issues around the bone parts, like if the greater tubercle, okay, if the decreased bone density, like here you can see the white patches clearly, but if there is a black shadows here, okay, and those black shadows presents only in a particular part. Clearly note this point. If the black shadow appears in the bone in a particular part, it's maybe an avian. If the black shadow is like the shadows, black shadows is randomized over the bone, so then it may be schizophrenic. So you have to differentiate the diseases and features in the definition. The decreased density of the bone, like the white will get decreased in generalized. If it get decreased in
Dear participant, kindly wait. As sir is from Tamil Nadu, there is a heavy rain and red alert, and there is a network issue also. So we have to check it again. 2 minutes.
hello, sir.
Ah, yes, sir. Yes, sir. Audible, sir.
Okay, okay. Can you please tell me where my network got cut?
Y-
Where I stopped my class?
Yes, yes, sir. It was in
Because I don't.
avascular necrosis. Avascular necrosis.
Okay, okay. Yeah, vascular necrosis. Okay.
Yes, sir.
In the avascular necrosis, uh, you have to check for the decreased bone density, like the black shadows. Okay, the black shadows will be here or in the particular part of the bone. Note this thing. If the decreased density of the bone or decreased white shadows noted in a particular part of the bone, then it may be either AVN, avascular necrosis, or it may be some external thing or some other thing like cyst or tumors. Okay, just note this point. If the decreased bone density or some shadows, black shadows, not a particular part of the bone, it may be either an avian or external thing like tumor or cyst. The shadow of the tumor and cyst may also look like a black spot in the bone. Okay, well, I will share some examples. In the X-ray, see here you can see the bone shadows is shared, okay, here, but just see the contrast shadow here. Can you see the black shadow, small black shadow here? So this black shadow is or it's the shadow of cyst or tumor. Maybe the avian or shadow of the cyst. So we have to differentiate those things. So if it's a shadow, then it will have some structure. Like as you know, the cyst will have some structures like so if it's an oval shape, if it's as a shape, then definitely it's an shadow. Okay, and those shadows, you can see those shadows here or here, even here also. Even it will placed in the cortex regions of the bone or shaft of the bones, wherever the part, and it will not present in the layers like the periosteum. Okay, the periosteum layer, the outer covering of the bone. Okay, it will not get involved with the periosteum, and the avian avascular necrosis will get involved with the periosteum. Okay, can you differentiate these two things? If the black shadow is presented, like just know this, if the black shadow is presented in any part of like randomized part of the bone, okay, and it's as shape, okay, then it's an tumor or cyst, okay. But if the black shadow is like you can see, this is the outer layer of the bone. If we zoom the X-ray, you can see the outer covering layer here. Okay. If the shadow is get involved with the outer covering of layer, then it's an avian. If it doesn't get involved with the outer layer, then it's an cyst or tumor. So with these differentiations, you can check. And to double check the avian, you have to check for the contrast of the black shadow. The black shadow will be look like this. Here you can see the black shadow, no? So this content of black shadows you can see here. So you can clearly say it's an avian in that conditions. Can you catch my point? It will be little difficult to understand these differentiation things. So I will tell you a point to differentiate the avian and tumor. Check for peritoneal layer. Sorry, not peritoneal, periosteum layer, the outer layer of the bone. If the shadow gets involved with those, if it's get involved, it's an avian. If it doesn't get involved, then it's a cyst. Okay, that's the thing. And the final point, everything other than these findings, you have to check for what like external objects, because in some cases, like the trauma cases, there may be some external objects uh, noted over the soft tissue area. Like I will tell you some example. I will tell you some example. Okay, uh, a 19-year-old female allergic with road traffic accident. Okay, and take it as an example. She's allergic. She's allergic with road traffic accident and had foot bone fractures like Lisfranc fracture. She has Lisfranc fracture. Along with there is massive lacerations over the foot. Okay, she came to the ER and there they did some wound wash, and they did some stitches, and then after that they referred the patient to Vartho to get the POP. There they got some X-ray views, like they took both three views: AP views, lateral view, and oblique view. They took both three views. So in those views, they saw some external objects like sand. Okay, here you can see the bone. Apart from this bone, they saw some white, dark white shadows, like bone-like structures. The dark white shadows they noted here, like a small spot. It's not even big. It's like a dot, like this only. This. It will look like the dot. So those things are the sand that entered into her skin in the event of accidents. So to remove the sand and stones, they operated the patients with C-harm in minor OT, and they removed the sand. After that, they took another X-ray and to confirm whether the previous dot spot, they noted no, whether those dot spots are 100% sand or it's an some other things are not. To confirm and to double check that, they did another X-ray and they checked and they confirm it as an sand. Okay, so to check for those external things, to, those external objects, we have to check for those things like the YM nails. Even the patients may have past history of surgery, so you can see the nailing or plating, or the patients. Even in some cases, the patient may have fracture. Okay, even some cases, the patient may have osteoporotic compression fracture, but they their quality of life didn't get compromised because of that. They will have some back pain, but they will work normally. Even though they have compression fracture, some of the people work normally. So they won't take x-rays or they won't even take medications because they will think it as a normal low back pain. The old age people, I am telling, they will think it is a normal low back pain. And after 2 or 3 years, if the back pain get severe, then after taking off x-rays, they will see some mal malunited of those things, those bones they will see. Okay, so in those cases we don't have the past medical histories, so we didn't expect the fracture in that cases. So to avoid those misdiagnoses, okay, so to avoid those misdiagnoses, you have to check these 5 points clearly. So the first second is to check the x-rays. The first one to check the X-ray contrast, whether it's an overexposed or low exposed. Then the second point is whether the X-ray is taken in a correct anatomical posture or position. Okay. Then the third one is to inspect the joints. In those things, you have to check joint spaces and vertical surfaces. In the joint space, you have to check for arthritis. In the vertical surface things, you have to check for dislocations. Okay. Then the fourth thing you have to notice is osteoporosis, I mean osteophenic changes and AVN. In the osteophenic changes, you have to differentiate between osteoporosis and osteophenic. Then in an AVN, you have to differentiate between AVN and tumors. Okay. Then the fifth point is everything else. Okay, that is you have to check for the external objects or some other things. Okay, presence in the anatomical structures, some other abnormal thing that presents in the anatomical structures. Okay, then along with that, you have to check for the continuity of the bones, and you have to check for some fractures. Here in the shoulder X-ray, the most common fractured things are shaft of clavicle fracture, neck of humerus fracture, or shaft of humerus fracture, the Buncut fracture or Buncut lesions that comes as a result of dislocations. Then, even in some rare cases, you can see the coracoid process fracture. If the patient had dislocation in the past, they may have fracture fragments in the coracoid process. Okay, then there fracture of tubercle in the greater tubercle. It's very rare. Okay, so this I'm telling means these are the common sites of fracture. Okay, along with that, you can check for the ribs also. Okay, these are the fractured things, common fracture things that will happen in the shoulder X-ray. As well as what I will share some other examples. Here I told you it's an PA shoulder. Here, here, just see the articular surface of the J joints is normal, but the articular surface of the AC joint is unparalleled. You can see the upper end and lower end. Both the upper end and lower end is unparalleled. So it's an AC dislocations. And in the AC dislocations, there are 6 types of dislocations. That's from according to Rockwood classifications. Okay. In that classifications, you have to mention whether it's what type of dislocations it is. Okay. Then you can see some black shadows here. Can you see? Can you see the black shadows? So, as you can see, there is a randomized black shadows. As you can see, the black shadows is not presented in a particular part of the bone. It's present everywhere. So, here you can notice the osteophenic changes. Here it's present in every part of the bone. So it's an osteophenic changes. It's not avian because it's not present in the particular part. It's present everywhere the bone. So it's an avian. And as for the fractures, you have to check some things. Okay. Then I will, apart from shoulder X-rays, I will start some other X-rays also. Here, in this X-ray, you can check for, sorry, it's not clear. So I will show you the full X-ray. Here, you can see the full X-ray here. So the wrist, as I told before, those 5 points is common for all the X-rays. So you can use these 5 points for all the X-rays that has been taken. Okay, except chest X-ray. Chest X-ray is different, and skull it's also different. Okay, apart from these 2 X-rays, you can use these points in all the X-rays. So let's check this X-ray. So to interpret this X-ray, the first 2 thing we have to notice are to check whether the X-ray is right or not. The first point is to check whether the X-ray is overexposed or underexposed. So the bone area, you can differentiate the bone and soft tissues. So the X-ray is not underexposed. You can clearly see, differentiate the bone along with the soft tissue. And to check whether it's an overexposed, you have to check for the structure of the bone. And the structure of the bones is normal. Like you can see all the part of the bone, like the head, shaft, okay, the two head and shafts, you can see all the structure of the bones clearly. So it's not underexposed. I mean, it's not overexposed. Then the second point is whether to check the X-ray is taken in a correct anatomical form. It's in the correct form. Okay. Then the third point you have to check are joint spaces. So here in the wrist X-ray, there are so many joints present, like the intercarpal joints, interphalangeal joints, um, MCP joints, metacarpophalangeal joints, okay, and distal radial nerve joints. There are different types of joints. So to check that here, you have to see the space between each heartbeats. Will have space, okay, but in some of the X-rays, you can't differentiate those spaces. So that means there may be an carpal dislocations or the X-ray is taken in an X-ray is not taken in a correct format because uh, let's take an example for this also. If the patients kept their hand in extended positions, like the wrist is extended, the X-ray is taken in the extension of wrist, then the the distal row of carpal bones will get overridden with the proximal rows. So there you can't see the space. As well as if it's taken in an flexion, the proximal row will get overridden superior to the distal row. Okay, if it's radial deviated or ulnar deviated, whatever the movements, if only the X-ray, the space you can see in a neutral positions. If the patient is slightly deviated the hand, also the intercarpal spaces you can't clearly see. So that you have to correlate those findings with the clinical features, like the symptoms of the patients. That's comes with as for joint suspension. And in that you can check for arthritis. Okay. And as for dislocations, I told you here in the wrist joints, it's very simple. Then the fourth thing, that is osteoporosis and avian. In this X-ray, there is no osteophenic changes and all. And here you can see the black shadow in the end of the metacarpal bones. Okay, so you may think, and this black shadows is not involved with the outer layer of the bone, that periosteum. So it's not avian. So you may think there may be a tumor, there may be a cyst, it's maybe a shadow of the cyst. You can think like that. But here in an wrist X-rays, some of, not some, most of the peoples will have these things because of uh, the arthritic changes. Like if the patient has gout or Varrier, Okay, if the patient is, even if the patient is anemic, they will have these changes. Okay, so you can't differentiate clearly in an X-ray. So that only you need one other findings like blood work to confirm the things. Okay, so these are the things. Then everything else you have to check for everything else, whether the external objects is present within this. Then along with the everything else, the external objects, you have to check for the continuity of the bone. Like here, the continuity of the bone is normal, and the carpal bone continuity, all the carpal bone continuity is normal, and those for metacarpals, it's normal. Sorry. Then, as for phalangeals, also it's normal, and it's an AP view. In an AP view, it's normal. Let's come with the lateral view. In the lateral view, you can clearly see. Sorry, you can clearly see the phalanx. Can clearly see the fractured fragments. It's an avulsion fracture. There you can see the fracture because there may be an volar plate tear or some other collateral ligaments. There may be a collateral ligament get teared. So that because of its tear, there is an avulsion fracture. Okay, so you can clearly note the avulsion fracture here. Apart from this, everything is normal. So these are the things we have to check. And these are the basic things you have to check. Apart from that, there are so many things in the X-rays. In each and every part of X-rays, as I told before, each and every joint has the different types of dislocations, and each and every joint has the different types of fractured sites. Like in the wrist X-ray, uh, the most common fractured things are here: radial stellar process or ulnar stellar process, Cooley's fracture, okay, Cooley's fracture. Along with that, there may be Boston fracture and the shaft of metacarpal bones fracture, phalangeal fractures, boxer fractures. These are the common fractures. Like the boxer fracture means it's an fifth phalangeal and fifth metacarpal fractures. Okay, those are the common fracture things we can see in the wrist. Okay, so those things and all you have to read in the theory. So I'm just telling here the basic things, the basic reading findings. Okay, so with this basic reading findings, you can interpret the X-ray by 60 to 70 percentage. To confirm the diagnosis 100 percentage, you have to practice and you have to read those things and all. Okay, if you can read those things, then you can clearly diagnose using X-rays 100 percentage. Not even if not 100 percentage, also you can diagnose it effectively. Okay, and you may have some confidence that my diagnosis is correct. Then why may go for some other investigations like MRI. Okay, you may have some confidence. Okay, then let's have some discussion sessions here. Like here, not hip X-rays. I will show knee X-ray directly. I will show some knee X-rays. Sorry, wait a minute. Ah, come. Okay. So, uh, as I told before, these five basic things is applicable for all the X-rays except chest X-ray and head X-ray, and it's also not applicable for pediatric X-rays. The person they have premature bone. Okay, the person who have premature bone, like the person under 18. Okay, the children's, the yearly adults. Okay, so that they have premature bone. So their bone, the epiphysis and diaphysis will not get fused to each other. Okay, so there will not uh, plate with with the end plate growth. Okay, the growth plate will not get fused to each other in those ages. So in those things, you can't apply the joint space because you can't see the space. You can't identify the space whether the metaphysis is a joint space or not. You can clearly check the joint space there, and you can clearly check the ligaments issues there because those things is not much matured enough to identify things. Then as for vertical surfaces, it's also same. You have three part of the bones so that you can clearly check the vertical surfaces. And for vascular and avian, you can check that thing. You can check the vascular changes on the avian in all the X-rays. And the fifth point, the everything. Fourth and fifth point, you can check in all the X-rays, in the pediatric X-rays also. But the second and third point, you can check. I mean, the third point and the first and second points, you can check in the pediatric X-rays. So, in the pediatric X-rays, all the conditions will comes under these classifications. That is Salter Harris fractures. The every conditions we came across in our OPDs, like uh, the picture elbow, okay, like the picture elbow and the Wasgood Slaughter's disease, okay. These things they have some specific name, but these are not different kind of conditions. It's a fracture. Wasgood Slaughter's fractures is nothing but it's an fracture that has some type in Salter. Okay, so it's a fracture of type 5. The type 5 Salter fracture in upper part of tibia is called as Wasgood Slaughter's disease. Okay, wow. So it will have some other names, and all the conditions will comes under this Salter fractures classifications only. So it's have five types, and you should know these five types. Okay, the first type is nothing but the epiphyseal plate. The epiphysis will get displaced. If it get displaced or if it's slipped away from the diaphysis, then it's an type 1 Salter fracture. And in and type 2, the diaphysis will get fractured. In type 3, the epiphysis alone will get fractured. Okay. And in and type 4, both the epiphysis and diaphysis will get fractured. In and type 5, both the epiphysis and diaphysis will get fused to each other, will get compressed. Okay. Because of the compression injury. Okay. So you have to identify the pediatric X-ray using these things. Okay. I think everyone understand the basic things.
Sir, we'll wind up our, we'll have question answer session, sir.
We will have question and answer session, sir.
Okay. Now,
Yes, sir.
hello.
Now itself. Yeah, yes, sir.
Okay.
Now itself, sir.
Okay. Okay. I will unmute you people, guys.
Oh,
So you can ask one by one. Unmute yourselves.
Uh, Excuse me, sir.
yes.
This is Niveda.
Okay.
Actually, I have a doubt. So,
Yes.
in
Okay.
X-ray, you have shown me if it is an osteoporotic layer, if it shows an shadow is in over the layer, it is an avascular necrosis.
Yeah.
And if the shadow shows inside of the bone, and you have mentioned that it could be a tumor.
Yeah.
But in some cases,
Hmm.
there are an hairy, it looks like an hairy substance, and some bone carcinomas also, it visibles like an hairy
Ah.
substance in all over the peripheral osteoporotic layer also.
Hmm.
So
That's
how do
only
we
what I'm telling.
differentiate? Yeah.
Humor is a different topic, ma.
Yes.
Humor is a different topic. So why I'm
Okay.
not getting into those tumors topic and all. But I just told the differentiation.
Okay.
Okay.
Yeah.
When it's come to tumor, there are different types of tumor. There are so many tumors you can
Yeah.
identify in the X-rays, and each and
Okay.
every tumors has some other signs.
Okay.
Okay, so
Yeah.
in most of the tumors, you have to look for signs. Apart from
Okay.
these findings, you will look for the signs.
Okay.
And as I told before,
Mm.
the avian, okay, the avian
Mm.
will not get involved with the periosteum layer. And
Okay.
you are telling some other tumors is
Yes.
involving with periosteum layer, but how
Yes.
can we differentiate?
Yes. Yes.
Ah, if it's a tumor that
Mm.
involving the periosteum layer means, okay,
Okay.
it will have
Okay.
some other findings also.
Okay.
Like in an avian, you can see the black spot in structured area.
Okay.
Okay, can you catch my
Okay.
point? Uh,
Yeah, yeah, yeah.
just imagine if it's an greater tubercle. Okay, just imagine
Mm-hmm. Mm-hmm.
greater tubercle. You
Mm.
spotted a black spot, and it's
Okay.
involved periosteum layer.
Okay.
Okay, and it doesn't have any shape.
Mm.
It doesn't have any shape. It's not
Okay.
in oval shapes, or it doesn't have any shape.
Okay.
Then it's an avian,
Okay.
because uh, the avian is nothing but it's an dead tissue. I mean dead
Yeah.
cells, because
Yes,
of
yes.
decreased blood supply.
Blood supply. Yeah.
Ah, okay, wow. So
Yeah.
the dead part will may happen at any structures of the bones. Okay,
Okay.
it
Okay.
will happen in one shaped areas.
Okay.
But the cancers, I mean the tumors or cyst, will have shape.
Mm. Yes, yes.
So you may have shape there.
Okay.
Okay, wow. So
Yeah, yeah.
from that you can differentiate those things. And the
Okay.
as I'm telling now, you can't clearly diagnose tumor using only X-rays.
Only X-ray. Yeah.
You need some other investigations also.
Okay. Okay.
Sure.
Okay, wow.
Hello, sir.
Oh yes.
Sir, this is Charan, sir. Sir,
Oh
I
yes,
have
sir.
doubt, sir, in X-ray, it is show like black matter means it is like osteoporosis only, no, sir?
Black spot means it's not osteoporosis. Actually, osteoporosis is a condition.
Yes,
It's
sir. In
not a
condition,
findings.
in bone we can see in black dots only more we can see, no, sir.
Ama.
That's why I'm asking.
That's what I am telling. You
Okay,
should
sir.
not confuse the difference between osteopenic and
Okay,
uh,
sir.
with the osteoporosis.
Okay.
Osteoporosis and condition.
Okay, sir.
You can't diagnose the osteoporosis
Okay, sir.
using X-ray alone.
Yes, sir.
you should need the blood investigations because
Okay. Yes, sir.
the patient may have those black spots, randomized black spots,
Yes,
because
sir.
of post-operative POP also.
Yes, sir. It will
Post-POP.
chances, sir. Yes, sir.
Ah, okay, wow. So in
Yes,
that
sir.
time, you can't tell it as an osteoporosis.
Yes, sir.
In the blood work, they will have increased calcium in blood
Yes, sir.
works. Ah,
Yes, sir.
so that you need blood works also.
Okay,
If
sir.
the blood works show decreased calcium
Okay,
and
sir.
the bone also shows randomized black or dark spots,
Okay, sir.
then you can confirm it as an osteoporosis.
Oh, okay, sir. Okay, sir. So
Yeah,
before that
osteoporosis,
osteoporosis confirmation, we should go for the calcium
blood work.
checking also, calcium level also in
Yeah,
blood.
yeah. But
Okay, sir.
most of
Okay.
the water operations will not go for those checkings and all
Yes, sir. We will
because they will
blindly go some. We will blindly go
ah
with that black spots osteoporosis only, sir.
yeah,
Now
because
you.
they will diagnose using some clinical experiences
Sir.
with aging. If the patients aged with 50 above or 60 above, they find some black spots, some black area randomized means, then they will consider it as an osteoporosis
Okay, sir. Okay.
and they will diagnose it
Okay, sir.
because they are not giving it an provisional diagnosis.
Yes, sir.
Okay, wow.
Yes, sir.
So they will make it as a diagnosis. But
Okay.
to confirm those diagnoses, you definitely need blood work.
Okay, sir.
If they are treating the osteoporosis means they
Okay, sir.
will check for blood work.
Okay, sir.
But most of the orthopedians will not treat for with the osteoporosis, so that
Yes,
they
sir.
won't prescribe blood works. They will blindly prescribe it, diagnose it.
Okay, sir.
Okay,
Okay,
that's
sir.
the thing. Okay.
Yeah, thank you, sir, for clarifying, sir. Because before I listen same osteoporosis, they said like if black spots more will be there, we can consider as osteoporosis. So that I am asked you, sir.
Oh yeah.
Okay, sir.
That's why
Thank you, sir.
I'm telling. Okay.
Thank you, sir. Thank you for clearing, sir.
Oh, okay, okay, okay.
Okay, thank you very
Thank you
much, sir.
so much, sir.
Hi, sir. Myself, Sai Shrija.
Oh yes, ma'am.
Sir, if there is a fluid-filled bubbles in shoulder joint, how can we find in X-ray?
Like you are asking fluid-filled substances
Yes,
in
sir. In
shoulder
shoulder
joint.
joint.
Uh,
Fluid-filled bubbles.
fluid-filled bubbles.
Bubbles.
Okay. Not all the fluid-filled bubbles will shown in X-rays.
Okay.
Note this point
Yes, sir.
because fluids and gases, fats, those things and all will seen in a MRI.
Okay, sir.
Okay, but in
Lumps?
that's what I'm coming to say. In X-rays, in some other cases, if the fluids filled with some other substances, like
Okay.
some other increased calcium substances, if the fluids is filled with calcium substances, means those areas will looks like yeah, with a violet and white layer. Okay, you can see the bright white layers over the spaces because the fluids is accumulated over the joint space. No,
Yes, sir.
so that you may see the excessive white depositions within the joints in some rare cases alone. Okay,
Yes, sir.
so most of the bubbles and all those things and all can't be diagnosed and can't be seen in an X-ray.
Okay, sir.
It's only dependable on MRI.
Yes, sir. Thank you, sir.
Okay.
Is there
And
any?
someone asked, oh yes,
If not, then sir will wind up the class.
Hello.
yes, sir.
Yes, sir.
Hello.
Hello.
Thank you very much for your effort, sir. Being
Oh,
heavy rain in your state and
Oh, one
network
doubt,
issues
sir.
also. Mm.
oh yes, pa.
Sir, I am Sriram, sir.
Oh yes.
Sir, so if you said if joint space is in osteoarthritis, joint space will be reduced, no, sir,
Yes.
knee joint. So my question is, for knee pain, you did a patellar grinding test, it came positive. So
Okay.
how can you differentiate between patellofemoral arthritis and osteoarthritis and tibiofemoral arthritis? But in all
Uh,
these three conditions, joint space it shows only reduced only, no, sir?
Actually, nowadays, every joint space in the lower limb and the spine
Yeah.
is reduced
Yes.
because of our
Yes, sir.
sedentary
So
lifestyles
yes,
and
sir.
because of
So it is
body
confusing to
yeah.
diagnose exact accurately. Yes.
Uh, so that's only you have to check for those three things. If
Yes.
either one thing is missing, then it's definitely not what it is. Okay, you have to check for the osteophytes, the extra bone formation, and degenerative
Okay.
changes. If the
Okay.
joint space reduction is presented along with these two findings, then only
Okay.
it's an arthritis. If it's not, there
Okay.
is no osteophytes, there
Okay.
is no degenerative changes. There is only decreased joint space. Means
Okay.
there may be soft tissue damage, like the meniscal damage, and the
Sir,
meniscal
but
damage also
ligaments we can't see in X-ray, no, sir.
that only that's meniscal damage also we can't 100% confirm it. Okay, to confirm
Okay.
the soft tissues, you need MRI. But if the
Okay.
soft tissues injury is presented along with the avulsion fracture, like if example the ACL is get complete teared,
Okay.
there may be avulsion fracture in the anterior part of the tibia or at the attachments
Okay.
of ACL. You can
No,
see the
sir. My
fracture
question is,
fragments.
sir, leave about X-ray, sir. My question is, you did special test, patellar grinding test, it came
Ah, yeah.
positive.
Oh,
So my question is, how can you diagnose accurately whether he is having ONE or patellofemoral arthritis
actually,
or tibiofemoral
that's what
arthritis?
I'm telling. Wait a minute. Uh, don't blindly depends on the special test.
Okay.
Special test is not 100% accurate. And
Okay.
even
We'll check
X-ray
for
is all,
symptoms also.
yeah, not symptoms. Uh,
Okay.
even MRI also is not 100% accurate.
Okay.
You know that even the patients taken two to three MRIs. In
Okay.
three MRIs, they shows different findings. Okay,
Okay.
so the MRI also don't have 100% accuracy. In that meantime, how can we blindly trust the special test?
Okay. So then how can we
If
diagnose?
the
That is my
patient,
question.
that's only you have to correlate with the symptoms.
Okay.
If the patient has
Okay.
nocturic pains, that's only comes with the inflammatory conditions and degenerative conditions.
Not a pain. That means nighttime pain.
Ah, yeah. Then
Okay.
some other crackle sounds like
Yeah.
crepitus.
Crepitus. Yeah.
Crepitus clinical features and nocturic pain. Along with that, you find those three findings in the X-ray. By correlate these three things, you can diagnose it
Okay.
as an OA.
Okay.
Okay, so you only have to diagnose by correlating the clinical findings with the
Okay.
radiological findings.
Okay.
If it doesn't get correlated, then leave it as an normal. Even the patients as degenerative also, if the clinical
మధ్యాహ్నం
findings is not correlated. Wait a minute.
Okay.
If the clinical
ఇప్పుడు
findings is not
కోమలానే
correlated,
పడుకోవాలి ఎందుకంటే ఎగ్జామ్ ఉన్నది కోమలాకి
no?
Okay, sir.
Excuse me.
I muted her, sir.
Oh, okay.
Yes,
If
sir. You got your point, sir. We have to correlate with symptoms, age
yeah,
factor, and special test.
yeah,
Everything we
yeah,
have to correlate.
yeah. After 30 years of age, everyone has degenerative challenges.
Yes,
Okay,
sir.
so that you can't claim everyone as OA. So
Okay.
they need replacement, they need medications, they need physio.
Hello.
Ah, we can't
Tell me, sir.
blindly diagnose everyone with osteoporosis using X-ray alone.
Yes,
You
sir.
have
Yes, sir.
to
Understood.
correlate with the symptoms.
Okay, sir. Understood.
Okay.
Okay. Thank you so much.
Okay.
We'll wind up, sir. We'll wind up.
Okay, sir. Thank you.
Thank
Thank
you
you for
very
the
much,
session.
sir. Sir, thank you very
Thank
much,
you,
sir.
sir.
Thank you
And
very much, sir.
guys who are still attending, I will share the certificate link. You just fill it before you sleep because tomorrow 4 p.m. We'll close that link. So everyone will apply for certificate, but you people apply early. Thank you everyone
sir.
for your participation.
Yes, sir.